Hi, this is Brian Kim. I want to share with you this case of a patient that I was doing just routine cataract surgery and suddenly developed iris prolapse and anterior chamber shallowing. And so I'm going to show you what actually happened, what I did, and this actually led to a posterior capsule rupture, and I'll explain the mechanism of how that happened. And then more importantly, I was able to recognize it fairly early in the process because things were very unusual. And I'm going to share with you what I recognized that was happening that was unusual, so I was able to manage it without causing further problems. So you can see I'm finishing off the rhexis here. This is just a standard cataract, nice pupil, standard cataract density. So I fast forwarded and I skipped the previous steps, and this is a hydrodissection. This is my capsule fornix hydrodissection technique. I place a cannula out to the contralateral fornix. But look here, as I pushed fluid, you saw no wave, but instead you saw a bunch of OVD come out of the wound. So again, I recognized that there was absolutely no wave, and a bunch of OVD came out of the wound and the chamber shallowed. So what happened here? As I was pushing the BSS with my capsule fornix hydrodissection technique, I believe that the posterior capsule got blown out. And because of that, the BSS was going into the vitreous space and it caused the chamber to shallow. And so I wasn't quite sure what happened, but clearly there was a lot of OVD that came out and the chamber now is extremely shallow. I put my finger on the cornea just to check the pressure, make sure there was nothing unusual like a suprachoroidal hemorrhage. And I try to hydrodissect in a different place. Of course, nothing's really happening. Again, I'm sensing something is just not right. So again, no hydrodissection wave, even though I pushed a lot of fluid in. You saw a bunch of OVD come out. I'm just pushing some BSS, separating the lens from the anterior capsule, but then I decided to come straight out here. So mind you, I've performed capsule fornix hydrodissection on thousands and thousands of cases successfully. I think my main mistake here was I normally perform a little bit of a wiggle to loosen the tip in the capsule fornix, and I think it was wedged into the capsular bag peripherally, and I didn't do that little wiggle. And as I pushed it, I punctured the posterior capsule. And so I really need to adhere to my own technique and my advice. You want to really wiggle the tip to create a little bit of space between the capsular bag and the lens material before you perform capsule fornix hydrodissection. So again, now that this has happened, and I know that something unusual is going on, the first thing you don't want to do is spin the lens. Anytime you're worried about the bag, you want to do a no spinning technique, which again, my technique of double chop, cross chop, and mechanical fracturing techniques, I'm able to disassemble the lens without spinning the lens within the bag. Anytime you utilize a technique that you have to spin the lens within the bag, you're in really big trouble because you're going to exacerbate that tear. And so you can see here now, I'm gently placing the chopper under the rhexis edge contra-incisionally, the Vica tip vertically sub-incisionally, fracturing the lens very delicately. You can see here I'm just trying to do minimal forces, lateral forces. I'm placing the chopper under the right heminucleus. You can see I'm just being very ginger because I know something's not quite right. And I'm performing the cross-chop maneuver, placing the chopper around the right heminucleus, hooking the peripheral lens, and pulling it centrally and crushing the lens in half, grabbing that first quadrant up very gently, using primarily vacuum to remove that piece out, and then using the chopper to pop that second quadrant up, but performing another cross-chop maneuver first. Again, I'm very, very careful here. I don't want to do anything to exacerbate things. So I'm just teasing that second quadrant up, lifting it a little bit, and then hooking the peripheral lens, performing another cross-chop maneuver very carefully. Using the chopper to hook that lens piece up. And right here, I try not to rotate the lens piece. Rather, I grab it with some vacuum, grabbing that left heminucleus up out of the bag, and then using the chopper to crush it in half, and then primarily using vacuum to start to emulsify the lens pieces. Again, I don't know the extent of the posterior capsule tear, but I'm strongly suspicious that something's not right. Again, during hydrodissection, you expect certain things to happen. And when they don't happen, you have to be very suspicious that maybe something went wrong. And so you can see here the lens pieces are coming out and then grabbing that fourth quadrant up with a little bit of vacuum, crushing it with the two instruments. And so obviously, if I've ruptured the posterior capsule, the hyaloid face is still intact because pieces are not falling backward. And you can see I was also very strategic, and this is what I do for every case. I always remove the endonucleus first. I don't like to remove the epinucleus together. I like to do them in 2 steps. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. And I'm starting subincisionally, carefully going around circumferentially, peeling the cortex from anterior to posterior. And I'm being very careful. I'm leaving that epinucleus there. So I'm leaving the epinucleus. I'm going after the cortex, and the epinucleus is acting like a shield for me. The epinucleus is acting like a shield, and I'm going after the cortical material. Because if I don't have that epinucleus and I have a posterior capsule rupture, it might invite that vitreous to come forward. But that epinucleus, again, is acting as a shield as I'm going around circumferentially, peeling out the cortical material. Right there, as I was going contra-incisionally, I know I grabbed something that wasn't the cortex, and it could have been zonules or vitreous, but then I had to release what I was holding there, and I'm pointing to my staff that I think that there's a posterior capsule rupture right there. So I'm using that cannula to show them where I think there's a defect. So I'm just kind of holding infusion, kind of think about what I need to do next. And then I decide, okay, I'm going to start to remove the rest of this epinucleus, and I'm going to discover where the defect is. So I'm going to go ahead and start to eat the epinucleus. And as I do so, you see a little fragment starting to float back. And you can see the posterior capsule defect right here. So I eat the rest of the epinucleus. Luckily, that tiny piece came right back and I was able to eat it. So here you want to keep a formed chamber and then push dispersive viscoelastic through the hole. Again, dispersive viscoelastic, it's better at plugging up holes like this so you can minimize vitreous prolapse, and then you carefully come out. I'm going to widen the incision with a 3/0 blade, and then I'm going to place the Sensor AR40 lens. Why? Because this is a great sulcus lens. You can optic capture the lens. And for whatever reason, if the lens dislocates later on, you can perform the Yamane technique on this lens. And so that's the reason I prefer this in this situation, because even though it's not quite for the sulcus, it does have an anterior rounded surface edge. And again, like I said, if this lens dislocates down the road, I can perform the Yamane technique with this AR40 lens. Now what's interesting is as the lens went in, the leading haptic went through the posterior capsule defect. So now, instead of it being in the sulcus, the leading haptic is in the hole and it's actually descending. And so obviously I didn't mean that to happen. So I'm asking for my micro instruments. So I'm going to use my micro forceps to grasp the leading haptic, grabbing it, popping it up into the sulcus, and then now I'm ready, tucking it into the sulcus. And then I'll use a Maltzman to dial the trailing haptic into the sulcus, and then optic capture through the rhexis, a buttonhole technique. Okay, so great, looks great. So I'm going to do anterior vitrectomy by manual using the AC cannula going to do bimanual anterior vitrectomy, making sure there's no vitreous in the anterior chamber. Go ahead and hydrate the incisions when I'm done. But one of the things I noticed is that I have a very shallow chamber. Very shallow chamber, and it doesn't feel like it's sitting right. Shallow chamber, and the optic capture just looks a little suspect. Again, mainly because the chamber is so shallow. And that is because there's so much fluid that was pushed into the vitreous space. And so in order to equilibrate this and getting the lens in a more appropriate depth, I'm going to place my pars plana trocar, indenting 3.5 millimeters posterior to the limbus, tunneling tangentially and then diving in, and then performing pars plana vitrectomy. And as soon as I do this, I get a beautiful deepening of the chamber. The lens is sitting posterior now, behind the iris plane. I have nice optic capture. And so I feel a lot better about this. So again, before, because I had to push fluid in, I had to put viscoelastic in, do the hole, the chamber was just very shallow. And rather than leaving it that way, I decided to perform a pars plana vitrectomy. As you saw, the wound was clear of vitreous. I went ahead and just hydrated my incisions, take the trocar cannula out. Fortunately, I was able to fill the eye with some fluid, and you can tell that the sclerotomy is self-sealing, and that is the end of the case. So again, posterior capsule rupture from inadvertent puncturing with the hydrodissection cannula. Again, this is not because of a poor technique. The technique is really excellent, performing capsular fornix hydrodissection. Again, this is just poor execution, which is typically the case with any type of complication, but early recognition of these cases is vitally important. And as long as you can recognize things early, that something is funny. And I noticed this immediately when I was pushing with the hydrodissection cannula, that I saw no wave, but I didn't see any wave, but I saw a bunch of OVD come out, which means fluid was going somewhere. But where was it going? Well, it was going through the posterior capsule defect into the vitreous space, causing the chamber to shallow, causing the OVD to come out. And I had a high index of suspicion that that was what was going on. So I performed chopping techniques that limited any movement of the lens material within the capsular bag, which again limits any further worsening of the posterior capsule tear. As you saw, it was a pretty small tear. I was able to put the 3-piece lens into the sulcus and optic capture it, and I was able to minimize any vitreous loss by doing it this way, and then finally performing pars plana vitrectomy to deepen that chamber more appropriately. So again, this was a iatrogenic posterior capsule rupture with the hydrodissection cannula, primarily due to poor execution. I definitely learned my lesson with this technique, and I have yet to cause another posterior capsule rupture with a hydrodissection cannula. Again, because I'm wiggling now more consistently, it goes to show every attention to detail matters with every type of case. And I've certainly learned my lesson, and hopefully this will help you in your future cases. So I hope this was helpful to you, and I thank you for your attention.